Okay, right. So, welcome everybody. This is in continuation with our, academic meetings online, which we are doing for more than now 1 year, almost 2 years rather. So, so this is a meeting where we come across real life scenarios which we have done, and we get many very nice and wonderful presentations where somebody has done challenging case, complex case. So they share it with on this platform, and we discuss, interact, and we learn. So this is the objective of this academy. And Arijit, are you keeping a control of this? Okay.
Yes, sir. Yes, sir.
Move. Next. Move. Then next slide. Okay. So this is it. And the last time, slow. See, let the control be with me, otherwise it becomes very difficult. Okay, next slide. Okay. So the as the functionality goes, the best case presenter award in the last academy session becomes a moderator. So this was Shailesh. I know. Have you checked with Shailesh, Arijit? Is he here?
Sir, he is not here, but he will not be able to join today due to some reason, sir.
Okay. Did you check with him?
Yes, yes. I've checked with him.
Okay. So anyway, so this is the functionality, and I'll moderate, and along with I'll miss Shailesh today. Next slide. Next slide. Okay. So these are the presenters today. Who will present those cases. Dr. Ayan Kar from Kolkata. Next. Dr. Qayoom Yousuf Bhat from SKIMS Srinagar. We have been having some really proactive participation from SKIMS. Next. Dr. Anil Sharma has already joined. He's from Livasa Hospital, Amritsar. Anil, welcome. I can see you are here.
Thank you, sir.
Okay, next. Dr. Joginder is from Gurgaon itself. I know him very well, very versatile interventionist. Uh, he's quite proactive. So we look forward from a presentation from Joginder also. Next. Okay. We keep on giving some, just acknowledgement of being here and presenting their wonderful cases. So whosoever gets the best presenter award, it's a small token. We send them as a winner. So this time, and Arijit is in charge of this. So he's trying to say, don't eat fried. So air fryer goes to the best presenter today. Okay, we need to cut down on our weight by utilizing these things. Next. Arijit, next.
Sir, we can start with the case
Okay,
presentation.
so I'll call upon the presenters, and I think Anil, you take the lead. Please start with your presentation, and we can interact and discuss about your case after that. Thank you.
Sir. Good morning, sir, and colleagues. Today, actually, I'm going to present one case, which is it's not a very exotic case, but situation was really very stressful. It is basically IVL-assisted revascularization of LAD after cardiac arrest in acute ST elevation MI. And myself is Dr. Anil Sharma. I'm from Livasa Hospital, Amritsar. Brief about the patient's history. My patient is a 52-year-old male and he presented with extensive anterior wall MI. While we were trying to make him for this primary PCI, patient suffered cardiac arrest in the triage only, and he had Brady's systole. We started with the CPR and transcutaneous pacing was done. Roshi was achieved. Patient was revived, although he was intubated and he was on high inotropes. And in a desperate attempt, we spoke to the patient's attendant and they wanted to do anything possible for the patient. So we planned for a primary PCI for the patient. And we shifted the patient to the cath lab. And on table, before starting the procedure itself, patient had second arrest. And there we started another session of CPR. And patient was inserted with the IABP, TPI, and because it was really very difficult situation for us, so we did only POVA, just a fluoroscopic shot of LAD was taken, and POVA was done to the LAD. Flow was established, and patient we shifted to the CCU with high inotropes, intubated, IABP, TPI, everything was there. So, because we wanted to see the brain status of the patient, so we waited for another couple of days. While 5 days course in the CCU, patient had high TLC, LFT were drained, creatinine was increased, which gradually settled down. He was on high inotropes. Patient had recurrent VT, at least one VT per day, and 2 sessions of CPR was given, and some VT were reverted with the pacing also, and overdrive pacing, I mean. Then patient was planned for PCI after, because he was conscious oriented. So we thought that brain is okay. So we did CT. CT was normal. So we planned for PCI after taking high risk consent, and patient was taken up for PCI. After that, CAG was done, which showed mild plaque in the left main, and there was thrombus with the total occlusion of the LAD, which was highly calcified. There was some minor disease in the LCX, and RC was dominant, which has significant stenosis. So plan was to do the culprit artery, but it was highly calcified, so we thought that we'll do I-VUS along with the IVL-assisted PTCA to LAD, and stage PTCA for RCA later on. This is the NGO. RC shot, we can see there is some significant stenosis in there. And as far as the left system is concerned, LAD hostel, total occlusion, some thrombus was there. Although this scene is not very clear, but it was clearly seen in fluoroscopy. And this is another shot for the same. And we can see the calcium chunk lying over the proximal LAD. Then assess femoral artery. Bilaterally we have taken, because already there was IVP, so we have to go to the left side, and we use a 7 French XB catheter, and we tried to negotiate the lesion, but this time it was very difficult to negotiate the lesion. So we tried different wires, but ultimately fielder FC helped us. So ultimately we crossed the lesion, and we gave some 1.5 balloon dilatation to the lesion, and we established some flow. And I-VUS run was taken, which showed there was a highly calcified vessel. Somewhere it was 360 degrees, somewhere it was 270, and so on. So we started with the sequential pre-dilatation with the 1.5 into 8, then followed by 2.5 into 12 at 12 atmosphere, then 3 into 12 at 12 atmosphere. Then we we gave pre-dilatation with the opium balloon also at high pressures, but we couldn't prepare the lesion well. So we thought we'll start with the IVL. So this is basically pre-dilatation only, and we can see we didn't get. Then this was the check shot after pre-dilatation with balloon. Some dissection was there, so we planned to cover the dissection also, and then we did IVL also. IVL gave us good preparation of the lesion, and bed was prepared. Then we planned to deploy the stent. Distally, we started because I-VUS was giving us a diameter of 3. So we started with the 3 only. And 323 was deployed distally, and proximally 3.5 into 33 was deployed, and it was dilated. Post dilatation was done. I-VUS run was taken. These are the NGOs. And I-VUS showed there was optimal stent expansion and good apposition and satisfactory lumen gain. Some areas were under dilated, which we dilated again. And these were the final results. There was some wire-induced spasm. We gave some adrenaline over there, and it opened, but TME2 flow was established. Then patient was shifted to CCU, but story didn't end over there. He had recurrent VT, at least one per day, and he was already on a amiodarone infusion. Overdrying pacing helped in between us. Then we, in a desperate attempt, we added maxilitine to the patient. He had 2 sessions of CPR post procedure also. Ultimately, he developed uh, sepsis because of ventilator associated pneumonia. He recovered. Then we planned for EICD, but patient thought that he will be having a better opportunity in another big center. So patient went Lama, and till my contact, patient was doing well and he recovered. So this is not a very like if I have done something very exotic, but I just want to know what else could have been done in this case. So that's why I'm sharing this case. Thank you.
No, Anil, I think this is wonderful case and nothing less than exotic. So don't be more, modest in saying so. I think this is the stuff which is saving a life. So this patient was practically gone, and you brought him back with all your efforts. It requires a good sense of taking an initiative and deciding the things right at time. So many things matter, but I think you have done a wonderful, fabulous job. And obviously, once the calcium on eyeballing is different. Calcium, which the operator feels that how the wire goes, how big is the resistance while passing a wire or a balloon, that tells you that whether you require a calcium modification device. And I think it was very fair since you had tried everything, it was not opening, you used IVL, and then later on the stent expansions look very good, and it was true austere lesion, so it had all kinds of difficulties. Patient was very sick, and you managed it absolutely well. So I mean, full marks to you for this, and it's a splendid job. It's a
Thank you.
splendid job. So there is no reason to be modest here, and I think take the credit. So that I think we all come across such episodes, such like patients in our practice, where the decision making is very critical, when to intervene, and then these patients who have a LED infarct, they still continue to do critical even after the opening of this culprit vessel, especially in LED. Like ventricular arrhythmias are going on, then prolonged stay, then prolonged ventilator, then sepsis, and then lactates, then AKI. So it's not an easy scenario. And then obviously keeping the family counseled every point is again a bit of a challenge, because family starts becoming desperate after 2 3 days. So they're usually the families, they have a resilience up till 2 3 days, and then it starts going down. So it's a big challenge managing these patients. So I think one thing which I have learned in my practice from the beginning, keep telling the prognosis to the family that we are doing our best, but still at times, patients even after stenting do not come out of these situations. So I overall wonderfully done. AICD, yes, is a different scenario later on, but once these VT storms settle after stenting, so this is, and then RCA is also pending, which may be done later on. But you mentioned the patient lost touch with you, but it's a splendid job. Any comments from other presenters? I can see Ayan is there, Joginder, Qayoom. So welcome for any comments. But Anil, I think we give total full marks to you.
Thank you.
I'm sorry, sir. I joined late. I was in a primary,
Okay,
so I
okay,
have
okay,
to
okay.
this
Why
case.
why cardiologists remain so busy? That is also a point of discussion which we should discuss at some point of time. But wonderfully done, Anil. I don't see any of the things which could have been done differently. I think you were a patient was in a messy state, and you did everything good to take him out. Only thing which I feel, that if finances allow, if patient family gets consult for Impella, these are the cases to be done on Impella.
Okay.
because I have done, somehow we are privileged that we get such kind of patients for Impella usage here in terms of financial thing. So we use 2 or 3 Impellas a month in such like cases which are cardiogenic shock, arrhythmias, big MIs. They tend to do better than IBP. Obviously, if no Impella, then IBP. But other thing is critical care management. That is very important post stenting in big LED infarcts. Keep chasing the lactate levels, keep chasing, the acidosis, the AKIs, urine outputs, and inotropes. So all these things are very, very important in salvaging a patient. If we do only stenting and then become little callous in not chasing the critical care very stringently, then also high chance we may lose a patient.
Sir.
So these all things important, and I think you have done wonderfully well. So all marks.
May I ask you one question, sir?
Yeah, go ahead.
So, do you have any experience with that IVAC-12 pulse catheter? I mean, is this a bridge between IABP and Impella? Have you seen any better results?
No, I haven't. I don't have experience of that. We have Impella pretty handy. Whenever we decide, it's ready in 2 3 hours. And as I mentioned, we get such kind of patients who give a consent financially for Impella. I have done 3 Impellas last month. One patient was like this. And thank God I did that, because during the procedure, now again, it was a very calcified lesion. Patient came after a evolved MI, but hibernation was there, 15-20% EF. And once we crossed a wire, nothing was going. So we couldn't get any balloon down. And then so I didn't expect that. So I was thinking it was calcified, but since it's a 15-20% EF, I was upfront, I was not thinking of rota. Then I did rota and sequential balloons and then stenting. And during that, patient had a hypotension, 40-50 blood pressure. Even the Impella waves became very dampened. And but then it picked up. And these are the situations where patient, if goes into a vicious cycle during a procedure, then probably may not be salvaged. So Impella did the trick. But then I understand it is 25 lakh device, not easy to be used in many of our patients. They are not ready for that. But I don't have experience of pulsed thing. But yes, I know, and I hope that Impella is now being marketed and manufactured by Merrill also. So that will cut down the price, and we will have the Indian Impala by in next 2 3 months. Okay. Thanks, Anil. Thank you. Thank you for a lovely presentation. So, Dr. Qayoom, it's your turn. Please go ahead. Impact on strategy and step up approach in calcium management. Eyes or I versus I-VUS. Please go ahead, Qayoom.
Is my screen visible? Am I
Yes,
audible?
yes, visible. We like to see you also. Your video is not coming. I'm not sure, but your screen is very well visible.
I will go ahead. I don't know why I'm not able to share my.
Just give a nod to your video approval.
Okay, sir.
Yes, it is there.
Good afternoon to all the panelists and esteemed faculty. It's an honor and privilege to present my case in front of such esteemed faculty and mentors. I would like to say that my case is not an exotic one or a complex one, but it is what we face on day-to-day basis every day in the cath lab and what we do on day-to-day basis. A word about the calcium. Despite exclusion from the major RCTs, we know that significant calcium is present in around 1/3 of the patients, and severe calcification is present around 20% of the cases we do on day-to-day basis. And we are going to see more and more calcium with the aging population and the epidemic of diabetes and CKD. We are going to see it on day-to-day basis. Why we are bothered about calcium? Because it prevents stent expansion. That is the reason for most of the events that occur after that. This was a study that was a pooled analysis from Horizon AMI study and Acuity study. It showed that as the coronary calcium increased from mild to moderate to severe, all the events, whether death from any cause, cardiac death, MI, stent thrombosis, target lesion revascularization, or any MACE, it keeps on increasing from mild to moderate to severe calcium. Another similar study by Ayan Sharma in 2019 again showed the similar things. As the calcium increased from mild to moderate to severe, the MI, target vessel revascularization, and MACE events keep on increasing. What are the modalities we have on day-to-day basis where from we see calcium? First is and foremost is the coronary angiography. How it misses 50% of the patients, as was seen in one of the first study by Gary Mintz. It showed that coronary angiography is only 38% sensitive in seeing the coronary calcium. And the same study saw that I-VUS was around 73% sensitive in seeing the coronary calcium. The recent studies are showing that I-VUS has a sensitivity of around 90%. OCT is slightly better in assessing the thickness, and it has a sensitivity of around 95%. And CCT, it has a sensitivity of around 95 to 100%. This was the study by the Zhang et al. In 2021, a popular study where they come up with an I-VUS score based on the 4 parameters: calcium arc more than 270 for more than 5 mm, and a 360 arc of calcium, presence of a calcified nodule or vessel diameter less than 3.5. As the score goes on increasing, the stent expansion is less and less, and you need more and more atherectomy to get a better stent expansion. But do we always need these fancy devices, these advanced devices? Again, one of the pooled analysis from Prepare Calc and ICER Calc trials, they divide patients with severe calcium receiving upfront rotational atherectomy, another group receiving modified balloons, and another group receiving super high pressure balloons. Surprisingly, we see here the stent expansion was same in all the 3 groups. There was no significant difference, although the success rate was more in rotational atherectomy. The stent expansion was surprisingly same in all the 3 groups. Another trial that was published this year only, Eclipse trial, again, it compared the upfront orbital atherectomy with the balloon angioplasty. Surprisingly, again, the MSA was same in both the groups, and 1-year target pressure failure was same in the 2 groups. However, the secondary outcomes were worse in orbital atherectomy group, including more dissections, more perforations, more slow flow, and 30-day all-cause death and cardiac death at 30 days. Another trial that was present in TCT this year that compared OPN balloon with the IVL, it again saw that in severely calcified lesions, OPN balloon was non-inferior to IVL in terms of stent expansion. So after this literature, I will like to go to my actual case. She was a 75 years old female. She was a hypertensive and diabetic. She had recently suffered a non-STEMI, and echo was normal with grade 1 diastolic dysfunction. The angiography was done at an outside hospital that showed a triple vessel disease, and she was advised a coronary ABG at our hospital. But in our hospital, she refused CABG and she wanted a PCI only. This is the angiogram that was taken at our center. We can see visually severe calcium from left main to LAD going to the circ territories also. This is the cranial view from the same, again showing severe calcium. So we kept a rota and an IVL standby in case required. But we first wanted to prepare some path and check the nerve of this lesion. So we pre-dilated with 2x12 SC balloon. And after that, we take our I-VUS. The I-VUS showed us 3 clear things. One, there was a thick arc of calcium 360 for a length of more than 5 mm. But at this area where there was a thick calcium, our luminal diameter was already 2.5 mm. And where there was a tightest lesion, calcium was hardly present for 120 degrees of arc. And we had a landing zone just before the ostium of the LAD. So we thought where the patient was, he had to pay from his pocket. We thought, let's go with a step-up strategy. So we took a 2.5x12 NC balloon. We pre-dilated from below up to the proximal part of the LAD. Here we can see we got good result, except at 2 places here where there was a thick calcium, and at the distal part where there was slight under expansion, we didn't get good results with the NC balloon. We again step up with 3x12 Wolverine balloon. dilated with low pressure at lower and at high pressure near the proximal part of the LAD. And after the Wolverine, we took 3 into 12 NC, dilated again from above at low pressures below and at high pressures near the proximal part of the LAD. And we rechecked out our I-VUS. And the I-VUS surprisingly showed some good results. We can see calcium fractures and multiple sites at 1, at 2, at around 4 and 8 o'clock. At all the locations, there were multiple fractures. So our calcium had yielded, and we are confident enough to go up with stenting now. We did a 2.75 into 28 stent in the lower down LAD, and then we stented the proximal LAD with the 3.5 into 24 stent. And we did a good appropriate post dilatation with 3.5 into 12 and 4 into 8 NC. This is the final result we got angiographically, a good decent result. However, the real check was the I-VUS, which was taken subsequently. And we can see on I-VUS near the distal part of stent, we get an area of around 10 square. And in the middle part of the stent, where the calcium was 360 arc, we got an area of around 8.07 square. The proximal LAD, we got an area of 12 square. With adequate stent expansion of more than 80% and without any complication and without much cost to the patient, we are more than happy. The simple take-home message for for this simple case was that imaging, intracoronary imaging is essential. It can change your device strategy. It can change your plan, management of the patient, and device choice is dictated by the morphology and not by the device popularity. And step-up approach is always a good and safe and cost-effective method. We can start with an NC, go to scoring and OPN, and if not, then we can go to other high-end devices. It's a balloon first is a safe, cost-effective, and evidence-based in balloon crossable lesions. However, it is not possible, we can go with atherectomy and IVL. And the endpoint is stent expansion rather than a specific device. We don't always need atherectomy or IVL. We always need adequate lesion preparation guided by imaging. Thank you for your patient hearing.
Right, Qayoom. Again, a very solid and robust message. And I liked your line, device choice is dictated by morphology, not by device popularity. I
Yes.
think this is absolutely right approach which you have done, and we know that many cases can be done if we are more perseverant about non-compliant balloons, scoring balloons, cutting balloons, and continue to do that aggressively. Then we can actually achieve a better MSAs, almost a similar MSAs if we use ROTA or IVL. So yes, I think you made it very clear. Uncrossable, undilatable. Yes, we look forward towards these devices, but still, if we want to cut down the cost, we can actually do it. Many cases, it requires more effort. It requires more aggressive pre-dilatations, making the bed ready in a better manner before the stent. And another simple method which we keep talking at many forums, once you are dilating any tough calcified lesion with a balloon, you know, once the balloon is inflated, check that in two orthogonal views.
True, true.
If there is that balloon is not opening in any of the orthogonal views, that means the bed is not getting well prepared. So this is a very simple method which tells us, and if the balloon is open in both orthogonal views, I think no need to take any device. So yes, and then only thing is the balloon to artery ratio should be almost 1:1, or maybe just a 0.25 lesser. 3 millimeter artery, you have to take at least 2.75 millimeter balloon to check whether it is inflating well, if it is a lot of calcium. So I think message is very clear, and it is synchronous with all the Eclipse trials by Ajay Kirtane and other data which you presented, that we can get away in many cases where we feel there is a lot of calcium with only aggressive dilatations with cutting balloons, NC scoring balloons, OPN balloons, and that may do the purpose. Thank you, Qayoom. Thank you.
Thank you.
The case
Thank
was
you.
also good. Right. Okay. So I think if there are no further comments, let's go on to the third case. Ayan is here. Ayan, you were actually the first one. So go ahead with your presentation. Ayan, you are from Calcutta. You are muted. You're muted. Unmute yourself, Ayan. Yeah.
Yes, sir. I'm sorry. Can you see my slides?
Yeah, we can see your slides. You can make a slideshow. Just introduce yourself. You are from Calcutta.
Yes, sir. I'm from Calcutta. I'm a senior consultant interventional cardiologist, and I also lead the heart failure services at Narayana Health, Rabindranath Tagore Institute for Cardiac Sciences.
Very nice. This is a private hospital.
Yeah, we're part of the Narayana group, sir. We
Okay.
have 22 hospitals all over the country, and we're sort of a quaternary care center. We are 650 bedded, and we have 5 cath labs.
Very
We
nice.
run an extensive heart failure program. I'm mostly in charge of MCS, mechanical circulatory support, and advanced heart failure. But
I
I
know.
also do PCI.
I know. I have been to Calcutta many times to Proctor Towers, but mostly in BM Birla, and there is one more center near airport. I did one case
No,
there,
no.
three, four towers in BM Birla. Anyway, please go ahead.
I think you should come to our center sometime.
Yeah.
So I think I think you has already set the stage for my presentation, thankfully, and so I will be presenting about my experience with adjunct balloons, and not just as primary. It'll be a set of cases which I'll be showing. It is my experience with balloons. And so this is what we generally look at when we talk about calcium. So if you look at OCT images in levo phases, a lot of things looks very simply looks as tight lesions, but you would often see if you were to do a good OCT, you would see specks of calcium, which is often 270 to 360 degrees. They're very difficult. So when you prep these lesions, that is what happens. You break the calcium. So it's very important that we need to break the calcium and modify the lesion before we decide to stent it, as important before you stent it.
But I think there is a connection issue. I think Dr. Ayan is not there in the panel as well.
Okay. So I think there is some connection issue with the Ayan. So until the time he comes back, let's go to the next presentation. Arijit, can you call him? Okay.
Yes, sir, I'm calling him. Yes, sir.
So he can reboot his laptop. Joginder, are you here? Joginder? So this is Joginder, your presentation, ACS patient. Yeah, Joginder is here.
Yeah,
Yes.
sir, but my presentation,
Welcome,
is
Joginder.
it
How are you?
coming? Is it coming, sir, presentation?
We can see that. Just make it slideshow and go ahead. Yeah.
Right, sir.
Yeah, go
Yeah.
ahead. And welcome.
Yeah. Good morning, sir. Actually, I did it just now only because I had the case in morning only. I
Oh,
got up, I was having a cup of tea at 7 a.m. Then I got a call. There's a cardiogenic shock with ACS. Then I
Oh,
thought ki I had let's present this only because I got the call yesterday only. So my slides were not prepared. So many I prepare it. So these are not the good slide. No editing. Just I
no
would.
issues, no issues. We require essence of the case. That's it. Message.
Yeah, sir. So I had a 67 year male with chest discomfort and breathlessness since 5-6 hours in 2:30 a.m. today morning itself. His BP was 58 systolic without inotrope at that time, and the pulse rate 157. It was AF with fast ventricular rate. ECG showed ST depression. I will show you. This is the ECG ST depression in the anterior leads and inferior leads, and ST elevation in the AVR. And heart rate was around 150. So we put him on high inotropic sport, and we shifted him after loading, shifted him to cath lab. And cath lab we have to intubate him because he was very sick at that time. And we this is the angio of the patient. RCA is fine. OM is 100% block, and there is a LAD also. There is haziness in the ostial area. So we put up a direct stent to this. Direct stent has been put to LAD actually, and now we are doing LCX. We have put up first stent 2 by 16 down, and then proximally it's 2.75 into 28. After stent, there was a slow flow. We can see that. And now I use the thrombuster for the delivering the. This is the final shot we could have it. And then we had a echo also. Echo is it's showing that there is a MVP also something because there is a severe MR also there. And this is the LV function as such after doing my PTCA. So we did angioplasty to LAD ostial and LCX OM major. We had a slow flow, significant slow flow in the LCX OM. We did give the adenosine and this nicorandil and epiphybatide through coronary also and through thrombuster to the OM also. The patient BP was 92, was 56 in the end, and with high inotropic pulse rate was 108. It was sinus. We shifted him to on an infusion on epiphybatide and nicorandil with high inotropic sport. The patient was quite sick from the very beginning, and now the issues are maybe renal shutdown will be there, and how he will make out, that is the point. So this was the case. I did it right now in the morning itself.
Right. So no, it's
IVP
actually
also is the one issue. We should go with the IVP or not. That is also the issue because BP is somewhere around 80, 88, 80 by 50 and requiring high inotropic force.
right. So these are the points which we have discussed in the first case also by Anil. So this is a tough situation. Obviously, patient is in very messy situation, and there is a good comment coming from Mukesh that it's Joginder, you are almost presenting a live case. So it is you have done a few hours back and presenting straight away. So good. It's quite a brave intervention. But my advice is go ahead with the IBP. Don't restrict yourself because still patient is in shock on high inotropes.
Right.
So you have done revascularization. We expect that things would improve. But then how much time it takes, what are the lactate levels, whether you are yourself
Starting lactate was 5 around.
so you're speculating a renal dysfunction, AKI. So IBP is going to help in, keeping up the mean BP on a higher scale, and that will also be important, with as far as salvaging all the hemodynamics are concerned for this patient. You are little fortunate. There are no arrhythmias. In
No
Anil's case,
arrhythmia,
there
yeah.
were a lot of arrhythmias happening. So I believe patient will come out, but go ahead with IBP, maintain the inotropes, keep the mean blood pressure above 70 if possible, 65 for sure, and then keep looking at arterial gases, lactates, urine outputs, everything. So
Right.
you have done best part that you have very swiftly done the procedure, direct stent to LED, and then OM was giving you a problem in terms of slow flow, which also you have done all the measures. But IBP should be there. Rather, don't wait for IBP. Even during the procedure, on one side, if your associate is there, tell him to prepare the IBP on the other femoral, where you are intervening. The contralateral femoral should be ready for the IBP, and do it as
Right.
early as possible.
Right.
So this is what I need to add on this. But otherwise, I think you have tried doing best possible and maximum possible.
So culprit here is
The good point why
as
I'm saying that patient will come out, his LV function has been totally restored.
yes, right,
LV looks very good. There
right.
is MR, and if there is a MR with cardiogenic shock with a MR,
That
again
will
the
add on to the reason.
IBP is of more utility.
Oh, right, sir.
So that will take care. And hopefully after revasc, MR itself will go down slowly, gradually, and then patient should do better.
Right.
What was the age of the patient, Joginder?
67, sir.
Okay.
Smoker and hypertensive, no diabetes.
Okay. Okay, great. So this was a good case. Thanks for presenting, but nicely done. I think this is what I say, everybody is now so skilled and more than that, charged up in dealing with all the complex cases which are happening all over the cath labs in India, and that is a real proud moment for all of us. Ayan, we
Thank you
lost you
very
in
much, sir.
between. Please
Thank
go
you.
ahead.
Sorry.
Sorry.
Yeah.
Yeah.
So somebody needs to unshare.
Joginder, can you?
Yes, sir. Yes, sir.
Yeah. I think this is where we lost us. So I think this was a patient post cabbage LV function normal. I think we are quite common. We see SVG's grafts. I think it's been a while since we've used a distal protection in these kind of grafts. But previously we used to do just normal non-compliant balloons to these kind of grafts. But I think of late with imaging we've realized that the osteal grafts are generally very fibrotic. They are not just plain lesions. So which is why of late we've been using. So we do a pre-dilatation. So if you see after the pre-dilatation with this balloon, there's a significant waste that still manages to stay out here. So and which is why I think this just wouldn't go with even with the 3.5, and this is going up to 14 and 16. So we imaged it, and you see this is fibrotic plaque out here. It is eccentric fibrotic plaque, and of course distal to that there is a stent which is distally to the osteal lesion, and there too you can see the stent is otherwise patent. So we do a bed preparation with a 4x15 NC traveler, and we also did a cutting balloon before that. So with a cutting balloon and with the 4x15 NC traveler, we've made very good bed preparation, and then we again followed up with an OP and NC. This is a super high pressure balloon. It doesn't have much of dog boning, and what it does is we go up with this at 34 atmospheres, and what we get is a very good lesion preparation. And then of course we stented with a 4x18, and this is what we finally get. So finally at the ostium of the RSVG OM, it's almost 11.37 millimeter square. I think the chances of TVF or target vessel failure rates on these are very low. So there's no edge dissection too on this. So this is the final outcome on this patient. This is what we are, I'd be happy to show. So it looks quite good, and it's quite fulfilling too. So this is another one, 61-year female. So this patient again had, despite triple anti-anginals, very bad angina, just wouldn't get better. She also had some MR. She has an EF of 66, and her angiogram showed a left main triple vessel disease. We offered her cabbage as the first option, but she refused. Now, in order to just show you, see, even in the levo phases of this angio, you can see there's a lot of calcium in the proximal LAD as well as the, this is almost the whole of the left main. And the same thing is what we see out here too in the LO caudal views. You can see there's a lot of calcium out there, and it's like a short left main with the LAD here. The LAD ostium doesn't look as bad as it should. I mean, so let me show you further shots. So we decided to, so this is what it was. Again, while pre-dilatation, a lot of wastes out here which just wouldn't go. And you can see there's a lot of diffuse disease along that path. And you see the uptake of the LED in epicranial. It's not an easy uptake. It's sort of, it comes down below and then goes up. So it gives you, there's a nice convexity which causes a lot of wire bias. And if you see the ostial LED in the third picture on your right, is very tight. It makes life even more difficult. So what we did was we decided to go ahead with a Wolverine cutting balloon out here, 4O balloon, and we bed prepared this lesion. I think that we had this in mind, but given a thought, I think this patient would have done better with maybe an IVL or a rota because of the calcium that it. But what's important is it's very tortuous. If you see the wire bias out here on the right side, very difficult to deliver devices with this kind of wire bias. I mean, we had a very difficult time negotiating the I-VUS catheter. The I-VUS catheter wouldn't go. I mean, with this kind of support as well as that wire bias. But what we see is with the pre-dilatation, you have almost a 270-degree arc of calcium. There's basically a lot of hyperlucency beyond the rim of the calcium out there. And you see the pre-LED ostium is not really that large, is not that tight for you to put in a rota. So a rota really wouldn't make much of a difference, but maybe an IVL would. So we did an overlapping stent to the LED first, and then of course we did another stent to the left main out here. And we did demonstrate some cracks before we decided to stent. So I was very hopeful that I prepared the lesion well and I was going to do a good job. But of course, hell broke loose after I decided stent to the left main, because despite doing this overlapping stent, we had this is a 4x24 stent in the left main, and it was just not. There was a lot of waste in the stent after we had finished stenting. Now I was stuck. So basically, we decided to do post dilatation with a 4 and a 4.5, but the waste just wouldn't go. So we needed a bailout again. So I often go back to the OPN as a bailout also in such cases. So we decided to take a 3.5 into 12 OPN and we went up to 36 atmospheres. So this is what it was before on the I-VUS. You see it's a malopposed stent. There are parts of the media which you can see around 3 o'clock. And after we did an OPN, this is what it became. So it becomes much better opposed. Of course, I think we could have done a better bed preparation to this patient. I think we would have done an IVL, maybe crack up that plaque a little better. And I think we would have got a nice round left main out here. But then that is something that it's a hind thought right now. I'd already put in a stent. I couldn't change the situation. So this is the final result of this patient. So this was previously what we started with. And this is what we finished with. Such was the tortuosity after I did the stenting. The biocompatibility of the vessel is lost, and it's very difficult to put in an I-VUS catheter through these two stents. It just wouldn't go. So I don't have really very good these things to show you, but I was just able to pass an I-VUS into the proximal ostium of the left main to understand what is the final MSAs I was leaving with. So we had an MSA of about 9.5, close to 10. So I think it was kind of something that I think was okay. So complex cases made simple. So this was a patient who had constant intradialytic hypertension. So we decided to go ahead and do a angiogram. What you see out here in the levo phase, there's a calcific nodule in the prox LED. There's a tight mid LED lesion, and this is a single surviving coronary. For the sake of time, I'm not going to show you the RCA because RCA is blocked. And what you can see is there's a lot of dense collaterals which fills the RCA. So which is why he was having a lot of angina and difficulties. So this is what the lesion we were looking at. While trying to do this, since it was a single surviving coronary, we decided to put in an IBP upfront because we were expecting a lot of hypertension while we did this. And if you can see out here, as I think showed you in the previous one, I thought there was the ostium of the circ was really tight. But when you do I-VUS out here, you see the circ ostium is actually widely patent out here. So it actually helped us manage the strategy. We wouldn't have to do a left main stenting out here. We could just figure out the calcium nodule out here, do the tightest part of the LED and come out. But then we decided to have some discussions on table. Before we decided to do change morphology, whether we wanted to do CABG to this patient again. We again had a talk with the relatives, but they were not very keen. It's a long segment disease, osteal LCX disease, MCS support upfront or an SOS basis, do a rota or a rotatripsy. So we were planned with all this, ready for all of this. So we did an imaging, and after that we did a pre-dilatation bed prep. We did this with our standard non-compliant as well as semi-compliant balloons, and you can see the IBP in the background on the left side corner of your. I think you can see that. So we had a very smooth sailing procedure, and after that we took out the IBP. We closed it with an angioseal. This is what it was. So now you see even the ostium of the circ doesn't look that bad at the end result. So this is what it is. So key take homes would be complex cases need very good planning and meticulous execution. So and it's very important to image because it helps you precise sizing, choosing the correct balloons, appropriate plaque modification tools. OPNs come as a very handy balloons, and of course, they're cost effective and with pressures which are almost equivalent to an IVL at the fraction of a cost. Just ensure that you avoid polymer jacket wires. There should be patience while deflating OPNNC balloons because they tend to be very sticky and they deflate very slowly. So be careful. Hypertension can happen, which is why you need to be careful. So avoid balloon ruptures and major dissections. I would always suggest you could downsize your balloon by zero point 0.5 when you're using very tough lesions. I think that makes it is very safe that way. Thank you, sir. Thank you for this opportunity. I'd be happy to take questions if there are any.
Sure, Anne. This was a very nice compilation of cases, and I liked the way you present. It was quite energetic. So, the message again is very clear that, while dealing with calcified vessels, we need to pick our choices. And I think that debate continues and goes on and on, whether only the high pressure balloons or some calcium modifying devices. So, there are two schools of thought. So, one, obviously, there is usually some inertia in, taking rota, or now we have orbital also with us. So, orbital is quite operator friendly. Only thing is, if the finance allows, obviously, financial issues are there with many patients because that adds up to almost 3 lakhs of cost. If a rota is lesser, orbital is 2.3 or so, and IVL is 3.3. So some financial extra burden on the patient, but if that allows, and we feel that it is a very thick calcium nodules, then better use it. But yes, otherwise, this is the way which you have shown. Cutting balloons and OPN balloon. OPN is a very good balloon. OPN doesn't, risk of perforation goes very low. If you have already have a caliber of the vessel on I-VUS, you can pick and choose the right size of OPN with 1:1 ratio and go ahead on high pressures. That is one way. So this is the message, and we keep following this. It is primarily the operator's discretion at that point of time to decide that whether they require a calcium modification device or high pressure balloons to prepare the bed well. But yes, the message is prepare your bed well before stenting. Don't be suboptimal in preparing the bed. Otherwise, you will face problems. You may face problems post stenting, and then you continue to pick and choose. After that, you're only left with OPN. Peristent calcium is a different ball game. If the stent doesn't open up, then excimer laser or IVL or OPN, these are the options. But practically, you're left with OPN if your stent doesn't open up well. So all cases are very good. Your graft case, your LAD case. Yes, I agree with the left main. Prior use of IVL would be more handy, to prepare the bed well. Because if the calcium is on the curves rather than a straight segment, that is going to be more troubling and more concerning in terms of stent expansions. Now the stent is also taking a curved shape, and with calcium in the vessel at curves, I think it's more tricky rather than a straight segment. So overall, very very well done, Ayan. Beautiful
So would
cases.
the other option be putting in an orbital? I mean, for that case,
Yes,
I mean, do you
yes,
think that?
yes. I use orbital. I have done almost 100 orbitals now. So this is very, very operator friendly. And the good point is it is better than rota in nodules because it is orbiting in an orbit. It is revolving in an orbit and gives you, if you are very patient, continue to give up and down, to and fro movement of the of this burr of the orbital atherectomy, that shaves off the calcium in a much better manner as compared to rota. I'm very comfortable using orbital now over rota. We have been a very aggressive rota user also, but after orbital my rota usage has gone down dramatically. It is very operator friendly, easy to use, and to and fro movements and at the curves. It is better because you can come back. The retrograde retrieval of this orbital burr shapes of the calcium better. Good.
No, but
Overall,
then
good
the
discussion.
FX trial, I mean, it shows very different kind of results, no? I mean, I would have expected calcium modification with rota to be much more superior to other forms. I mean, so
Yeah, I
it's
tell
sort
you,
of
we have used rota since many, many years. Now, rota only makes a good hole. If the calcium is too much protruding into the lumen, rota may be effective non-crossable lesions. But otherwise, orbital seems to give you a better decalcification overall. You have to be patient. Yes, I agree. There are studies which tells us that, but in my experience, in almost 100 cases now, orbital, if you are very patient, shaving of the calcium, the stent expansions, you will achieve much better.
I see. Thank
Okay,
you so
great.
much, sir.
And yes, in the end, it is MSA, MSA, MSA. End result is dictated by stent areas, maximal stent areas which you get, which we get, whichever we get. Qayoom was very emphatic in pointing out this message that it is the MSA which is going to matter. If you achieve a good MSA, whichever way, I think your long-term patency and long-term results will be very good. Okay, thank you. Some of the lovely cases. I'll come to the last part of it, my presentation. I'll share it with here. Okay. So normally what I do, since we do a lot of structural also in the end, I keep a structural presentation for the end. And this time I gave this talk in the CSI only. CSI is going on in Delhi. So 2 days back I gave this talk. So unleashing the tricuspid valve interventions. I'm sharing the same here. Now we have a good experience with tricuspid valve interventions, including the TriClip. Now, TriClip is a newer thing in India, but we got chance. I have done 5, 6 TriClips, almost 60, 70 mitra clips. So I'm just giving you a overview how the TriClip is being done and how, and one case of valve in valve for tricuspid valve. So we know that tricuspid valve is a forgotten valve, ignored valve, but then it is of extreme importance to the heart and to carry on the life, because the right-sided heart failure is also very tricky. That not only affects the survival, that affects the quality of life, then liver problems can happen, ascites, right-sided heart failures. It's going to be very, very problematic for any patient. It can be. So we see these patients on a daily basis. Ayan also mentioned he's in charge of heart failure clinic. So he must be also, everybody must be coming across such patients where there's a severe TR and progressive RV dysfunction patient's life actually becomes a hell with these kind of problems. And we know if we intervene the tricuspid valve problems at appropriate time, we can do a lot good to these patients in terms of survival and the quality of life. This is a right ventricular function assessment. We know there are many parameters. TAPSE is one, RVS dash is one, RV fractional area change is one, RV strain, RVEF. So this is how the RV dysfunction is judged. And this is the algorithm which tells us severe TR. Obviously, we start with the OMT. Now OMT patient is doing fine and the RV function is intact, fine. We stop here. But patient is symptomatic despite OMT, then we start evaluating the patient. And obviously there's a progressive RV dysfunction. The RV strain is higher. The PA pressures are high. So then we evaluate the patient. Patient is low risk for surgery. Heart team comes into play. We decide if he's a low risk for surgery, he has to be evaluated for surgical tricuspid valve intervention, be it tricuspid valve ring or a repair or a replacement. But then there are problems in that also, because usually what happens, these patients have high PA pressures. And now look at this, if the PA pressures are high, more than systolic PA pressure more than 70, then it's going to be a problem after any surgery. And even we have to think twice before intervening in these patients on percutaneous basis. So yes, if the patient has a systolic PA pressure of more than 70, we take all the measures to get the PA pressure down. If they are dynamic PA pressures and PA pressures come less than 60 after a treatment, That means if we treat the tricuspid disease, patient will still do much better. So I'm talking that once, having said that, I'm talking a scenario where the left-sided heart problems have already been managed. If there is MR, if there is MS, obviously that has to be managed first. We are not talking of only tricuspid valve intervention. If there is a left-sided involvement there, so we have to manage the left-sided involvement first. So then if the PA pressure is less than 70 and there is a severe TR, we start looking at the underlying mechanism of TR, whether it's annular dilatation, mild teeth, leaflet tethering. This is a good case for annuloplasty ring, but if the patient is suitable for surgery. But if there is a good leaflet tethering and jets are coming from the commissure sides, coaptation gap and depth is less than 10 millimeter, this is a good case for triclip. So I don't, endorse the trick valve. Many people use that. I have done few, but I think that is not going to change the pathogenesis. That is only for some quality of life improvement. So we know the data is there that if we intervene on tricuspid valve regurgitation, if we control it, the patient, all parameters and hemodynamics are going to improve. So not going in this detail, let's come to the cases. This was our first case, 37-year-old male patient, had a tricuspid valve replacement, Paramount 33, done many years back, but now the valve has degenerated. Patient was highly symptomatic, significant tricuspid stenosis, significant TR, right-sided failures, and significant RV systolic dysfunction. This is a young guy. So obviously in such scenarios, a valve in valve is a very good approach. Look at the tricuspid valve. Florid TR, Florid TS, and this is first two videos are the start videos once the tricuspid intervention was done. The third video shows a tricuspid valve not opening well at all, and TR and TS. There hardly any opening of the tricuspid valve, surgical valve is there. So this is a three Mancio, which is very important, uh, for analysis, perimount valve, and this is how this procedure is done. It is very simple procedure. As far as the valve deployments are concerned, you only require a good analysis of the CT, and if you know the previous valve size, that makes it further easier, and it is a very simple procedure. You need to take care of few points. This is we do it from the jugular access. Usually the tricuspid valve, valve in valve procedures, we do it from the jugular access. From the jugular access, we're crossing the tricuspid valve. This is an Platzer wire, stiff wire across the valve going into the pulmonary artery. Place this wire deep into the pulmonary artery so that it doesn't buckle back while you are advancing the valve. Valve is a bulky device. Now, only precaution which one has to take is because from the jugular you place a sheath. Now, this sheath cannot go ahead because the distance is less. So, it will be half in, half out. So once it is half out and you advance a valve into the sheath tends to get disrupted and the bleeding may happen. So you need to take care of these small points while advancing this, and have a good nick in the skin, because once the valve enters the sheath, it's going to expand it quite a lot. Now, this is expandable sheath, 14 French going into 16, 17 French, depending on the valve size. So this is also a bigger valve size. So these are the some of the points to take care of. And once you are here across the valve, uh, rapid pacing, but now we have done it without rapid pacing also. You have to be very meticulous while inflating this valve slowly, gradually, and it has to be a two operator phenomena. One operator is dilating the valve and you are managing so that it doesn't go down or doesn't come back. Look, we're going very slow and still trying to dive down a little bit. So these corrections are required while it is fully inflated, and go with the full inflation, the volume, and look at that, and then some PVL, and we go with another dilatation. This is 30.5 my valve. So this is now, see, absolutely circular inside the valve, and everything looks good. Look at the second video. It's opening up nicely, no gradients, no PVLs, and case done. So it is very easy to deploy. Small things one has to keep in mind. Now this is a tedious procedure, try clip. So I give you a scenario. This is a first patient I did, 83-year-old female patient, had a previous AST closure. Now, the previous AST actually was the reason for RA-RV dilatation and a severe TR, which was moderate initially but progressed to severe. And now the lady landed with RV failure. There was atrial fibrillation also, fast ventricular rate. That was a triggering point. Left-sided system was okay. There was a moderate MR, but more than that, it was fine. So ASD closure, moderate MR, severe TR with florid right heart failure. We took time to stabilize the patient, and then discussed that she's a good candidate for TriClip, 83-year-old, surgery in no manner possible. The lady's son lives in US. I had a good discussion with him on phone, and then he planned to come back. Look at this. This is our RA dilatation and the florid TR into the RA. So this is isolated triclip procedure which I planned. The third video on top is a transgastric short axis video on T. This is very, very important. Without this, we cannot do a triclip. So problem of tricuspid valve clipping is that this is a valve which is very difficult to image. And even if you image, once you grasp with the clip, you are not sure how much tissue you have grasped. Whether you should leave the clip there, because if it is not a good grasp, the clip is going to embolize. So you have to be very sure how much tissue you have grasped and where the exact points you have grasped. This is a tedious thing with dry clipping. So this is how it is done. Now see, the second video shows. Now this is a 3D picture, the first one which tells us where the regurgitant jet is coming, and now the clip is coming. See, look at that. Now RA to RV, once we get the advance the clip, it has to have a good trajectory, and that formation of trajectory itself is a challenge in triclip. We don't have a dedicated triclip as yet within our system. It is the same mitra clip device which we use for the triclip. And look at the third video. Now we have almost got it on top of the tricuspid valve and a good trajectory. So that looks here good. So now with this is the trajectory we need to have, but it doesn't come easily. There's a lot of movements, rotational movements, which we have to do on this device. So we are over the tricuspid valve, and then we go to the transgastric videos. Why it's not running? Okay, then we go to the transgastric. I can come back again. Probably it's running only once. Okay, see the last one. Now this is a transgastric short axis, and here we look at the orientation of the clip. Not an easy ball game, but then if you do more, you get more reflexes into that. So checking both the transgastric short axis and then the RV inflow outflow views on T. This is now our clip arms are open and we're coming below the tricuspid valve, and look at this, we have captured. Now we have closed the clips and some reduction in the TR is already done. So there the first clip deployed. We were comfortable, but there is still a regurgitant jet coming medial to this. So obviously it requires another clip. So this is second clip coming in the third video on the medial side, and look, then we are now in the fifth video, you can see we are grasping again the tricuspid valve. So in the transgastric view, you have to look at the regurgitant jet. Septal anterior, usually septal anterior is the first grasp, and then we move slightly posterior anterior is the second grasp. So this is how after the two clips. Now imagine, just remember the previous florid TR. We have decreased that florid TR just to a mild TR. So this is how it is done, and this was the T images. This is a fluoroscopic image. The first clip is going down. The first clip is done in the second video. We have detached the clip device from the clip arms, and then the second clip comes. Third video shows the second clip. And then, as I mentioned, we showed you a T image which reduced the florid TR to the mild TR. This is another case, a 79-year-old, very frail lady, diabetic, hypertensive. I only did the LED stenting 2023 after anterior wall MI. She has a severe LV dysfunction, 25-30% because of that anterior wall MI. So now she was landing with heart failure. In last 6 months, almost 4 admissions, every admission comprising almost of 15 days in the hospital. Very disturbed with refractory heart failure, no other way to move forward. She's only 45 kg, 79-year-old, 25% EF, severe MR, severe TR. Obviously, she's almost reaching end stage if we don't intervene with any kind of intervention. So after a good discussion with the family, very nice army family, so we discussed, this is, see the MR, see the florid MR and a florid TR. Fourth video shows a florid TR, rampant TR, and then severe MR. So I planned a mitra clip and tri clip both in one go. So first mitra clip, one clip done, and that mitigated the MR like anything. And then the TR, I'll show you the T images. This is a fluoros images. After a septal pierce, mitra clip is done, and then we came to from RA to RV to do the tri clip. So this is a mitra clip. First two videos, next two videos, the grasp is done on mitra. Look at the third video. The mitral, the MR is reduced significantly. And then the fourth video shows a tri clip coming over the tricuspid valve. All those maneuvers are being done, and then a tri-clip grasp is taken in the last video. Look at this. The third video is a grasp done, and fourth, look at the TR. So we actually reduce the TR again with only one clip to mild and mild, less than mild MR. And this is a good result achieved, and patient is doing fine. No heart failure admission. This is done 6 months back. In last 6 months, no heart failure admission. Although she continues to have some hyponatremia, she's a very frail lady, but now walking, mobilized, no heart failure admission. So this is the beauty of these procedures, that if done in a good selected cases, we can salvage these cases really well with a good quality of life to these patients. So yes, finance cost is little bit of factor, but as we grow further, I think we can actually give a lot of better quality of life and survival to these patients. Thank you. Any questions about this? I think I'll be happy to answer.
Excellent cases, sir. So, if I may ask, in your first case where you did the tricuspid valve, I think. So, how were you pacing the? I mean, RV. I mean, what is your?
So I tell you. So in first, I have done around tricuspid valve in valve almost 10 cases. So one few cases we paced from the right atrium, but right atrium, because we are actually doing lot of stuff. We are taking the valve. If we have a TPI lead in right atrium, it's going to get disrupted. It will move here and there because of all these motions. So then in few of our cases, we had a safari wire in the LV, and we paced from the LV. So then we learned that tricuspid valve is, RA to RV is not a very high velocity jets. We done 2-3 cases without any pacing. So out of 10, 7, 8 initial case, 7 cases we did with pacing, either from RA or from LV side. But last 2 cases we did without pacing. Only thing is one has to be really stringent, meticulous, judicious in while it is being inflated. The mantra is keep it little back into the RA, and then little push once it is getting inflated. So once it is a 70% inflation, until that time, 70-80%, until that time you can move. But once it anchors, there is no movement. So just be sure that it is anchoring with 10% to the RA, 90% to the RV, and then you are okay. So that comes because we have done 10. So after experience, we know that how to manage it.
So you have right and left IJV axis?
No, only right. Only right. Only
so
right.
with that, So you have two sheets, I mean, so one for the TPI and one for the valve.
No, TPI we're going from down, femoral vein.
Okay, sir, sorry.
Yeah.
Sir, why not do just, I mean, a valve? Why do a tri-clip? I mean, so I'm just asking you
No,
upfront.
triclip is only for the native tricuspid. If
So
there is
for native tricuspid, you cannot put a valve, no, sir?
no,
It's not possible?
there is no approvals with a native mitral or a native tricuspid. There are no approvals.
Even if you had MAC or something around it, no.
MAC is off-label use, and
Okay.
tricuspid MAC is not there. I mean, mitral MAC we have done two cases, but then that also you require a 280-degree of circumference at least of a severe calcification.
Thank you, sir.
Tricuspid annulus is a very heterogeneous annulus, So it's
Not a
very
stop.
difficult. It's very oblique, this, that. So up till now, only valve in valve is indicated. But yes, now that evoke valve thing is happening in US, where the anchor is the tricuspid valve leaflets. But somehow it is not available in India so far. But maybe in a year or so, we'll get this valve in India too.
So do you do
But
balloon annuloplasties to these tricuspid valves as bailouts? I mean, let's say patients who come with severe TS, tricuspid stenosis. We have a lot of patients who have these bioprosthetic valves with tricuspid stenosis. Would just, I mean, balloon annuloplasty, would it help? And balloon valvuloplasty, like we do for the aortic valve or BAV, have you
no,
have?
see, if it is a bioprosthetic valve stenosis, balloon valvuloplasty, you can try it out, but I don't think that's going to stay. So I think it's going to come back. The mechanism is the degeneration of the tissue valve. It's not the commissural fusions like it happens in the rheumatic heart disease. So rheumatic heart disease, we break those commissural fusions, but that is not applicable. The pathogenesis is the total leaflet degeneration in the bioprosthetic valve. That may give some relief for 6 months and it's going to come back. We have done few, but it doesn't stay long. So in that, but if it is valve disruption, already a bioprosthetic valve failure, it is very easy to do a valve in valve for the tricuspid. But finance is little constrained.
Thank you so much.
But tri-clip is a very quite a tedious procedure. You require a very good transesophageal guy with you who understands everything and who keeps and you both of you as an interventionist and a T guy, you keep talking at length and deciding about all the nuances of the grasp, how much tissue is already grasped and whether to release or not. It's a difficult procedure, but all difficult things cardiologists are known to do. Only thing is you have to understand everything and go ahead, and then with more the volumes you do, you develop your reflexes well.
Thank you, sir.
Okay, great. So thanks for being here on Sunday. There are few in the chat box. What happened? There is near. Okay. We granted TV. Forgotten. TR etiology in this case. TR etiology in this case, Qayoom was trying to ask.
In the first case, sir, that young male patient who had a severe mitral tricuspid valve replacement.
So it is a disruption of the prosthetic valve. Patient had a bioprosthetic valve at tricuspid position, and that valve dysfunction has happened, and valve dysfunction can lead to TS, TR both.
I want to know what was initial indication. They had done a TVF.
Initial indication was, I think I showed that. Again, it was a annular dilatation because of something. I don't remember that. Sorry, I showed the echo. So it was again a severe TR at that point of time, and valve replacement was done, but pathogenesis I don't know exactly. Okay, great. So that comes to the end of today's.
May I
Uh,
ask one more question, sir? I'm
yes,
sorry.
yes, 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 I
So
am.
when you do valve in valve for these tricuspid valve, is the longevity of these, I mean, let's say the my valve in the tricuspid position, is it higher or lesser than the aortic valve?
Definitely, it is higher than the mitral. There are two reasons for that. Usually, tricuspid annulus is a bigger annulus. Like in this case, it's a 30.5 valve. So, and the velocities and the shearing stress is lesser on the tricuspid valve as compared to the mitral valve. Uh, so, also, I have a strong experience while doing the mitral valve in valve. I have done mitral valve in valve almost 60, 70 cases. If the mitral valve size is 25 or lesser, the degeneration is faster. And two of my cases have actually degenerated on the mitral side, which was done 5 years back. So the life was only 5 years on two cases, but usually the life is around 7, 8, 9 years. If the valve size is bigger, the valve in valve is bigger than 20, 25.5 or 26, then obviously the degeneration is much slower. So tricuspid valve degeneration is much slower than the mitral. Since we have done only 10 and the mean follow-up is only 2, 3 years, we don't know exactly. But yes, this is a clear-cut scientific logic behind this. The bigger the valve, the degeneration is smaller. The lesser the velocity is on the right side, again, it is slower than the mitral.
Thank you so much.
Thank you. It was wonderful interacting with all of you. Thanks for being here on Sunday. Last point, I think we reached that point of labeling and announcing a winner. So it is not any contest, but yes, everybody presents with the best of their cases. One announcement we have to do, and I think today I felt that Anil did the case in a quite a meticulous manner. So, and he was very modest in saying that I haven't done anything exotic. That was definitely exotic, Anil. So today, we announce you as a winner of this, and you will receive a Best Case Presenter award, which Arijit will be doing the honors for me. Thank you.
Thank you, sir.
Thank you. And let's keep meeting. Let's keep discussing. Idea is learning from each other. Thank you.
Thank you.
Congrats.
Thank you.
Okay, bye.